Hello my dear fourth year medical students of EMP. My name is Dr. Sabri Said, Professor of Obstetrics and Gynecology, and Shams University. Today I am going to present the topic of post-term pregnancy, a fairly common obstetric problem that we encounter in clinical practice with significant implications on the emotional satisfaction of the pregnant woman, and its tactful management is crucial for achieving the best perinatal outcome while keeping a minimum cesarean rate. By the end of this lecture the student should be able to 1. List the various methods for estimation of the gestational age. 2. Define prolonged pregnancy. 3. List the various causes of prolonged pregnancy. 4. List the fetal and maternal complications of prolonged pregnancy. 5. Appropriately manage cases of prolonged pregnancy. Post-term pregnancy refers to pregnancy that has continued beyond 40 weeks. Prolonged pregnancy is commonly used to describe pregnancy continuation beyond 41 weeks. Postdated pregnancy refers to pregnancy that lasted longer than 42 weeks or 294 days beyond the first day of the last menstrual period. Fetal mortality, fetal death rate in utero. Neonatal mortality, death rate within 1 month of birth. Perinatal mortality, fetal and neonatal death rates combined. Tau, transabdominal ultrasound. Oligohydramnios by tau, reduced amniotic fluid volume, AFV, i.e. DVP, deepest vertical pocket, 2 cm or AFI, amniotic fluid index, 8. TVU equals transvaginal ultrasound. CL equals cervical length as measured by TVU. Bishop score equals measure of cervical ripeness, favorability, for IOL, induction of labor. Etiologic factor, cause-effect relation proved and explained by studies. Risk factor, just association between the risk factor and the effect with no proven causation. Antepartum fetal monitoring, methods to assess fetal well-being include DFMC, mother counting the fetal kicks over a 4-hour period until 10 movements are counted. NST, non-stress test, i.e. cardiography equals graph of fetal heart rate monitoring x30m. BPP, biophysical profile, ultrasonic monitoring of fetal movement, breathing, tone and AFV and NST. Modified BPP, NST and DVP only. UADF, umbilical artery Doppler flow study. The incidence of true post-term pregnancy equals 7%. It gets higher, 12 to 15%, in poorly dated pregnancy with no early, 20 weeks, U.S. Wrong dating of pregnancy is the commonest cause of erroneous diagnosis of prolonged pregnancy. Associated risk factors include nulliparity, previous history of prolonged pregnancy that required induction of labor, male sex. Post-term pregnancy is more common in obese patients with BMI greater than 30, one of the rare modifiable risk factors. Placental sulfatase enzyme is essential for the feto-placental unit to synthesize estriol hormone that seems to have a role in the initiation of labor. So its deficiency plays a role in the pathogenesis of post-term pregnancy. Fetal cortisol also play a role in the initiation of labor, and its deficiency is a rare cause of post-term pregnancy such as anencephaly, adrenal hypoplasia, and congenital hypopituitarism. Prolonged pregnancy has both fetal and maternal complications. The fetal complications include IUFD or neonatal death that is doubled by 42 weeks, 2/1000, and 6-folds higher by 43 weeks, 6/1000, compared to 1/1000 stillborn rate at 38 to 40 weeks. Macrosomia, if the placenta continues to function normally, can lead to dystocia and birth trauma. Conversely, fetal growth restriction with loss of subcutaneous fat and other features of post-maturity syndrome affects 20% of cases as a result of placental aging and insufficiency after 41 weeks. Oligohydramnios due to fetal oliguria may result in cord compression during labor, with subsequent variable decelerations in the CTG causing non-reassuring fetal heart rate, thereby increasing the caesarean section rate. Meconium-stained liqueur. Increased motilin hormone in the hypoxic post-term fetus increases the intrauterine passage of meconium, and meconium-stained liqueur becomes thick in the presence of oligohydramnios. Meconium aspiration syndrome describes the sequelae of neonatal inhalation of meconium particles in the amniotic fluid, resulting in chemical pneumonitis and neonatal respiratory distress, NICU admission for mechanical ventilation, pulmonary hypertension, fits, and rarely, hypoxic ischemic encephalopathy. Post-maturity syndrome describe a clinical picture that affects about 1/5 of the post-term babies due to oligohydramnios and meconium staining of the scanty amniotic fluid. Its manifestations include subcutaneous wasting and skin wrinkling, low APGAR score, FGR, NN hypoglycemia and convulsions. Meconium aspiration syndrome. Absent lanugo hair and peeling of skin. Long nails. High risk of infant death. This slide shows signs of post-maturity. Maternal risks include emotional stress and anxiety from the expected complications. Fetal macrosomia can result into vaginoperineal tears and increased caesarean section rate due to CTG decelerations, hypoxia and/or cord compression, or cephalopelvic disproportion. The diagnosis of post-term pregnancy is based on accurate estimation of gestational age as validated by 2 or more of the following methods. Certain LMP plus VE pregnancy test within 6 weeks of LMP. Doppler auscultation of fetal heart tone at 10 to 12 weeks. Fundal height at umbilicus at 20 weeks. US dating by crown rump length at 6 to 12 weeks or less accurately by measuring the biparietal diameter 20 weeks. The earlier the dating scan, the more accurate estimation of the gestational age and hence the less incidence of post-term pregnancy. First trimester US corrects 40% of dates as opposed to only 10% by second trimester US. IOL is needed only in 3% of pregnancies dated by first trimester scan but is needed in 7% of those dated by second trimester scan, 20 weeks. Dating by early ultrasonography alone is a very accurate method for predicting ED. The earlier the better. First trimester, CRL, plus 3 days. Second trimester, BPD/FL, plus 1 WEEK. Third trimester BPD/FL/AC, plus 2 to 3 weeks. Cerebellar diameter, distance between two cerebellar hemispheres, has fairly constant linear relation to gestational age up to 32 weeks and is useful for those who missed the early dating scan. You can see in this slide the 3 important ultrasonic measures of gestational age. The crown rump length on the upper left corner for first trimester scan. The biparietal diameter on the lower left corner. The transcerebellar diameter on the right with its constant linear relation to gestational age up to 32 weeks. Ultrasound is the best method to diagnose oligohydramnios by lack of deepest vertical pocket of amniotic fluid of more than 2 cm or the amniotic fluid index or AFI of less than 5. AFI is the summation of the deepest vertical pockets of the 4 uterine quadrants. Deepest vertical pocket or DVP is measured in each quadrant at a cord and limb-free space as shown in the left. The picture on the right shows a case of severe oligohydramnios with very scanty liqueur. Management of postterm pregnancy depends on many factors. 1. Gestational age. 2. Absence/presence of maternal risk factors. 3. Evidence of fetal compromise. 4. Maternal informed choice. 5. Cervical ripeness and favorability for induction. Successful management depends on effective counseling of women and their full involvement in the decision making. There are only two lines of management for prolonged pregnancy. Either immediate admission for cervical ripening and induction of labor, or expectant management by close monitoring of fetal well-being until spontaneous onset of labor. Both options are equally acceptable if the pregnancy is uncomplicated and the mother is reliable for compliance to the regular fetal surveillance and fetal kick counting. During expectant management, the fetus is followed by both the mother. Postterm baby should be delivered by IOL if there is evidence of placental insufficiency by one or more of the following criteria: daily fetal movement count 4/12 hours. Amniotic fluid index less than 5 or deepest vertical pocket less than 2. Non-stress test showing non-reassuring fetal heart rate or decelerative trace. Absent or reversed end diastolic flow in the umbilical artery. Indications for delivery include also BPP 4/8. NST showing unprovoked decelerations and reduced variability. End diastolic flow of the umbilical artery is absent or reversed. Among the various methods available for fetal surveillance, modified BPP seems to be the most practical and cost-effective test to achieve the best perinatal outcome at the lowest induction rate during the expectant management of post-term pregnancy. Routine IOL at 41 weeks reduces the costs of fetal surveillance and hospital stay with reduced maternal anxiety and perinatal morbidity and mortality. Disadvantages of immediate blanket policy of induction of all uncomplicated prolonged pregnancy is the increased cesarean section rate if Bishop score is low 5. At 40 weeks of GA, post-term pregnancy, IOL can be offered if favorable cervix for induction as indicated by high Bishop score above 6. Cervical ripening before induction increases the success rate of labor induction. Methods of assessment of CX and favorability for induction include: 1. Clinical Bishop score. Favorable if 8/13. 2. TVU, cervical length measurement, favorable if 15 mm. Bishopi score is very useful clinical method to assess the cervical ripeness before deciding for induction of labor. The IOL is likely to succeed if the Bishop score is 6 or more out of 13. This slide shows the items of the Bishop score and will be discussed in detail in the face-to-face presentation. This is a transvaginal ultrasound showing the cervical canal with the internal OS and external OS marked. Offer routine induction of labor at 41 weeks regardless of the fetal condition after informed consent with or without using cervical ripening agents according to the Bishop score to maximize the success rate of induction of labor. Amniotomy to diagnose thick meconium, if present risk of meconium aspiration, continuous fetal assessment with electronic fetal monitoring. Routine induction of labor should be offered to all low-risk pregnancies at completed 41 weeks. Regardless of cervical ripeness. Expectant management by close observation of fetal well-being awaiting spontaneous labor is the alternative if the pregnant mother refuses routine induction of labor at 41 weeks despite adequate counseling regarding the better perinatal outcome by IOL at 41 weeks without increasing the cesarean section rate. Maternal satisfaction is related to the mode of delivery and the fetal outcome rather than whether the onset of labor was induced or spontaneous. I would recommend reading this topic from the link below. I look forward to meet you tomorrow in the face-to-face presentation to discuss the different clinical scenarios related to prolonged pregnancy. Thank you for listening and good luck. Please read the links attached to the lecture and be ready to the clinical case scenarios to be discussed in the F2F session. Thank you.